So I hope that this works. Okay, I hope you can see it.
Yep.
Can you see my
we
screen?
can see
Yeah?
perfectly well.
Okay, great, good. Now, thank you much. First of all, giving me the honor to speak in front of you.
Oh, thank
I
you.
remember my time in Salvador de Bahia. It's I think 6 years ago, in the year of the World Championship, and and so we had a wonderful time there, in a very interesting city. We had some interesting sightseeing and meeting friends. And I remember that I was also jogging with Oswaldo, so we had a quite interesting.
In the lighthouse, in the Bahia
yes.
lighthouse,
Yes,
Salvador lighthouse. Yeah.
Exactly. That was okay. Well, now our topic today is not is perhaps also history, but a different history. It's in cochlear implants and other hearing solutions. And I just want to briefly divide all solutions in to the mode of stimulation. So the acoustic stimulation is just giving by the hearing aid to the outer ear canal. The electric stimulation is by the cochlear implant directly to the nerve. And then we have the mechanical or vibratory stimulation through implantable hearing aids. And the vibratory energy is delivered to the inner ear either through the bone or through the middle ear. Now, that means that we probably, for all types and degrees of hearing loss, as you see it here in this chart from Cochlea, we probably have some solutions. Now, unfortunately, not all solutions that were on the market are still available. For instance, the DAX or Darcy here, Codax device has been withdrawn, and also the Carina has been withdrawn, so that we probably have some gaps here, especially in the area between this degree of hearing loss, the mixed hearing loss, with mild to moderate sensory neural component, and the cochlear implant. And that's, I think, the current situation, so that we still that we cannot really cover the whole field anymore due to this withdrawal of the products from the market. I mean, mainly for economic reasons. Now let's go for the first thing, a diagnostic procedure, where we have, I think, everything available from audiometry through imaging, through also the omics, and can also make a kind of prediction for the patient about his future course of hearing loss and what would be the best solution for him, not only today, but also in the next years, the following years. And I think that's important, that we always keep in mind what will be in 5 years' time if we speak about the solution today. Now let's first go to bone conduction devices. We actually have a lot of interest now, especially due to some new developments. So the classic one is just the percutaneous with the screw, as we can see here, still in use, very powerful, but of course has some issues with infection and cosmesis. There are some transcutaneous solutions such as the Baha Attract, which basically is magnet through the skin. And then we have active implants where the active component is implanted like in a cochlear implant. Of course, it's not an electrode, but a mechanical stimulator. And we have an external speech processor, so like the bone bridge. Now, all these devices bypass the middle ear, and they stimulate the inner ear through the bone by vibrations. And of course, they have some limitations due to this fact. You see, I'm very conservative, saying bone conduction thresholds should at least be 30 dB or better. Then they definitely work. And there are several indications. We know malformations, chronic otitis, but also cases after tumor resection and so forth. Now, due to development in the processors, which have become more powerful, you can, of course, extend your indication criterion and probably can go down to something like 40 to 50 dB bone conduction threshold and still have enough or sufficient stimulation of the inner ear. That is true for the direct connect. Now, if you look for this Baha effect, of course, there is a dampening, and you have to reduce the effectivity by about 5 to 15 decibels. And the same is true, of course, for single-sided deafness. When you go for cross solution, then you have to stimulate the other ear, which also reduces the effectivity. So this is only for the hearing ear with a direct connect. If you have the other solution, then of course your thresholds of bone conduction will go up, and you can serve patients, let's say, up to something like 30 dB. Here's some data from our patients. You see 58 patients, and that's basically the bone conduction threshold down here across frequencies, and that is monosyllable word scores. Now, if you would go for something like 60 dB, the patient should have, which is kind of, he can use the device in everyday situation, then you see that if you go up with your hearing loss, so bone conduction threshold becomes worse, then you see there's kind of cut off somewhere here. So that means between 40 and 50 dB, you see that the performance drops. And that is where we set our criterion today. So we wouldn't go for more than 40 dB bone conduction threshold, just based on our data we have. So that's just to summarize. So here we have the limitation, that's 40 dB. Single-sided deafness, we would go only for 30 dB. That's basically our clinical schedule we use. Now, the active Bahas, there are two actually available. The one is the bone bridge from Adele since several years, and now also recently the Osea from Cochlea, and other companies will come out soon with the same type of solution. So what they do is they have the active component implanted, which means they need, of course, an external processor for information transfer and for energy supply. And so the patient has to wear this button on the head, and then the internal system is driven and activated. Okay, now the main difference is that, of course, with these devices, transcutaneous ones, your rate of revisions, complications, and explantations is much lower. So you see, our experience we had with the percutaneous one is 21% some kind of revisions or explantations, whereas with the bone bridge, it's less than 5%. So, and I think it clearly shows where the future will be. I think that these percutaneous devices, with a few exceptions, for instance, patient needs repeated MRI, then by time they will probably disappear from the market. Okay, now let's go for the next group of implants. These are the truly acoustic implants, and the only one left on the market is the vibrant sound bridge, which basically is inertial actuator. Shown here, it's a kind of permanent magnet driven by the coil, which is stimulated by alternating current, and then you get forth and back movement, as you can see here on this small animation. Now, this device is in use over 20 years, initially only for sensory neural hearing loss, but today mainly for patients with some type of conductive hearing loss. And you see kind of the indication scheme. You can serve patients who have some degree of sensory neural hearing loss, mainly in the high frequencies. The device, however, has some weakness in the low frequencies, and probably would say at 500 Hertz, the hearing should be not worse than 45 decibels or 50 decibels. Several options to couple it to the ossicular chain. For instance, you can combine it with TORP, with PORP, also with stapes. You can use different types on the round window, as you can see here, so that you stimulate also the ear through the round window. And this all is possible as long as you drive the inner ear in a sufficient way. And these patients, of course, have good improvement preoperatively to post-operative, you see a huge improvement in word recognition, or here SRT, also in noise. So they have significant improvement if you stay with the right indication criteria. Okay, now if these devices don't work, then the patient basically is a candidate for a cochlear implant. And our current criteria is that the patient should have less than 50% monosyllable word scoring with hearing aid. And if he has equal or less, then the cochlear implant will probably give him better hearing. And that's then, of course, something we can offer to the patient. Now, cochlear implant replaces the function of the inner hair cells. It stimulates the auditory nerve directly, and we can also create some tonotopic stimulation. So you see here one example, one contact is activated and a bundle of nerve fibers is then activated consecutively. But this graph already shows the problem that we do not activate single nerve fibers, but always a bunch of. And this is the reason why these devices can, so to say, give tonotopic information, but only in frequency bands instead of tones. And therefore, for instance, tonal hearing, like a music listening, is much worse than with acoustic hearing. Okay, but they give enough information for speech understanding. Our surgical technique is standardized. We use it since many years, retroauricular incision, exposure of the bone. We create the mastoid, the bone bed, and then we expose the middle ear through the posterior tympanotomy, then exposure of the round window membrane. And in most cases, we use approach through round window, only in a few cases where, for instance, we have obliteration or there is a kind of a very narrow niche, then we also go for some enlargement, like here for, let's say, cochleostomy, and then we can insert the electrode very smoothly. We fix the electrode in, especially lateral wall electrodes, in this bone niche. You see it, press it in so that the electrode cannot move. We always take post-op CT scan in order to confirm that the electrode position is right, and also how deep the electrode is inserted. Special cases, well, there are different techniques. For instance, for obliterated cochlea, like split arrays, first and second turn can be drilled out, and we can place them there. The frequency of these cases has come down, I think, due to the fact that we see those patients with post-meningitic deafness very soon after the event, so that we can, let's say, be faster than the obliteration is. But still, of course, we see it. Malformations is a huge topic. I think we see all kinds of, like common cavity, like cochlear aperture stenosis, as you can see here, but also incomplete partitions. So for each of these malformations, we need a special solution, which can be, so to say, offered. Now, there are some patients who have no internal auditory canal, or there is no cochlea, then of course cochlear implant won't work. These are candidates for an auditory brainstem implant. Here you see now some features of surgery. Common cavity after opening, you see the gusher. We have to deal with this. Normally, we can basically just close the cochlea and can handle this gusher. We rarely need any kind of lumbar drainage. But of course, these inner ear situations are less favorable for stimulation. We don't know where the nerve fibers are, and therefore the result might be very variant. Complications, yes, we have it. Medical complications in about 3 to 4%. Most of them can be managed conservatively, but a patient like this here, where we have a skin breakdown, we need surgical intervention. Then we have complications from technology. So implant device failure in our series overall is about 2 to 3%. Some devices we know had some issues where the failure rate was much higher, but due to corrective actions, I think overall the reliability of the implants has been improved over the decades and is favorably low compared to other medical implants. Here you see an issue of another complication, which is electrode migration. You see here initial position of the electrode, and then over time, the electrode was basically migrating out of the cochlea. And so you have to go in and reinsert it, which just shows the importance of a good fixation of the electrode in patients. Now, cochlear implant is a success story, yes. You see that from the first implants in the late 70s up to today, there is a huge improvement. And from contact to word of sound, patients today can discriminate speech. Some also enjoy music. There is, of course, a huge need. You see candidates in Germany, only 1 million, and implanted about 55,000. So a lot to do. Then we have speech test results. I think also interesting to see that with old implants, patients had a slow progress, and especially speech and noise, they did quite poor. Compared to modern implants, where they have a steep progress and have much higher scores at the sentence test in noise now. So it shows the impact of technology and technology progress, which really has brought us up in our results and also in the indications. Now, if you summarize our results, you see from about 10,000 patients, today we can say that 80% of the adult population have open set speech understanding, can use the telephone. In children, it's clear that they can achieve near to normal auditory and speech development, but this is mainly related to duration and age of deafness and time of implantation. The earlier, the better. And also bilateral implantation gives additional benefit for our patients. But still, we see a huge variation in results and performance here just from children. You see the range of comprehension score. Some have 0, others have basically normal hearing. And still, this is a huge area for research. We don't understand it really in all our patients, why they do well and why they are poor performance. Okay, now with the improvement in technology, we also are able to serve patients who have residual hearing. And it means that we see more and more patients which have the high frequency deafness like here, or still residual hearing across frequencies. And the question is, of course, what would be the best treatment? Is it always only electric stimulation, using a long electrode, or is it sometimes possible to preserve residual hearing and still use the existing acoustic hearing together with electrical stimulation, so-called AIS? That is something which has been the main topic of our work in the last years. Now we have to keep into consideration that the cochlea itself is very variable in length and in height, and which means that if we want to, let's say, cover the cochlea for stimulation, either completely or partially, we have to look on the length of the cochlea. And this can be measured today just from the CT scan, and then we can make a kind of selection of the electrode or insertion depths. You see here kind of possibility to make a model of the cochlea, and then you can make a virtual surgery. You can place your electrode, so to say, virtually into it, and then you see how deep you would come with. The cochlear coverage, that means the part of the cochlea that is covered or reached by the electrode, is important in terms of what we achieve with speech understanding in electric stimulation only. So you see, if the coverage is complete, it would be 1. If it's 0, it's 0. And here you see all the variations in the middle. Now, when we look on patients with different cochlear coverage, we see that the best results are achieved with a coverage of about 0.75. That means 3/4 of the whole cochlea are somewhat reached by the electrode. And this is true for different testings we have done. So what we would do for our patient, that we go measure the cochlear length, and then we choose, you see, from our portfolio of electrodes, the appropriate one, which gives us this kind of coverage. And here, that's our recommendation just for the MED-EL devices. So if you have a small cochlea, then we use 24 millimeters, medium-sized 28, long cochlea, then the flex soft, which is 31 millimeters. So that's basically a rule of the thumb we can derive from it. Now let's go for patients who have a lot of residual hearing and who still can use it by their hearing aid. And you see in those patients, high frequencies can be replaced or restored with the electric stimulation, while low frequency are still given by the hearing aid, and we call it electro-acoustic stimulation or hybrid device. Now, of course, we want to preserve the residual hearing, but the rate of preservation is dependent on the length of the electrode. So let's say for a short electrode, which is only 15 millimeters, the risk for become deaf is 7%. But if you go for a long electrode, like 28 millimeters, the risk to become deaf is 35%. So of course, if you want to preserve your residual hearing, you probably would go and use only a shorter electrode. Now, the downside of using a short electrode is shown here. If you have good preservation of residual hearing and the patient can use AIS, then your scores, for instance, here speech and noise, are very good, something 80% or so. But if this patient loses the hearing for some reason during surgery or after surgery, then he probably with a short electrode drops down to something which is very low, like 20 or 25%. So that means if we choose a short electrode for the reason of hearing preservation, it might be a bad choice if the patient has lost his hearing and is dependent on electric stimulation only. Because longer electrode, for instance here, shown a longer electrode for electric stimulation only, gives him better scores. So we have a trade-off, and the question is how to overcome. Well, we developed this concept of partial insertion, which means that we use a longer electrode, but insert it only partially. So for instance, here it's shown you have a long electrode, but you insert it only to a certain extent to cover the high frequency area of the patient cochlea. And with this, we try to minimize the risk of becoming deaf. But in case the patient would lose hearing, we could just go in again. And the second step, move the electrode deeper in. So the afterload the electrode then deeper. And we have developed a kind of selection tool where we can, based on the length of the cochlea and the residual hearing of the patient, we can, so to say, calculate how deep we would like to insert a given electrode. And then we do it, insert it, and as you can see here, so the insertion depth is marked here on the electrode, then it's inserted and it's fixed. And you see here the CT scan post-operatively that some electrodes are staying out, some contacts. That is basically then due to this partial insertion. Of course, we can also use monitoring, EKG monitoring during the surgery, which helps us to look on the residual hearing while we insert, and then we can follow the signal. And if the signal, you see, as it's shown here, goes up, grows, then it's fine once while we insert, and it should stay like this. If we have a drop, then we can, so to say, correct our insertion. We can stop or we can pull it back, so that we have an additional tool to increase our rate of hearing preservation. I'll just skip it. So, okay. Now we see here on the result again, one patient has been implanted, that is his that is his post-operative threshold, well preserved, and this patient then can use electroacoustic stimulation. Here you see a larger series of patients where we did it. You see, for instance, here Flex 24 was only partially implanted, 18 millimeters, or Flex 28 only 20 millimeters on average. And you see the hearing preservation rate, very good preservation in 70 or 60%. This is a rate of deafness, and only one patient lost his hearing. So I think it's kind of a concept that probably works. And you see here the results of AIS doing very well. HSM sentence test in noise. You see patients go up after 3 months, 6 months. And you see they have very high scores with this kind of combined hearing. And I think it shows that we should aim at really achieving it. Okay, so summarizing, patients who have little residual hearing, the low frequencies, we would go for electric stimulation only, use the appropriate length of electrode. Patients with good residual hearing, low frequencies, we would go for ARS and try to preserve residual hearing and using this concept of individualized cochlear implantation. Now, future, of course, we want to become better. We want to serve patients with presbycusis, but this means that our preservation rate has to go up, something like 90%, like in staple surgery. And of course, there are several tools we can use. Today, we concentrate on better surgery, for instance, using robotic systems, but also drugs that are administered together with the implant to reduce the trauma reaction. Just show you some things. Here, drug delivery to the cochlea. We can use the catheter to inject steroids right at the time of surgery, and then we insert the electrode. The recent development, the most recent development is now a drug-eluting electrode. We started a clinical study recently where we have an electrode that basically is coated with dexamethasone, and the electrode releases this dexamethasone after implantation. And the first results we have got are looking quite promising in terms of reduction of impedances, but also hearing preservation. But there are very preliminary data. The second one is that we use robotic surgery, that we go for kind of using a robot to help us to insert the electrode in the most atraumatic and best direction. And you see here such a system where a trajectory is planned, and then this trajectory is basically followed by help of a kind of tool that exactly gives the trajectory for drilling down to the cochlea and also for electrode insertion. And you see here how it's made. It's basically a drill path. The chick is made intraoperatively, depending on the patient's anatomy, by the planning. And this chick then is, you see, brought then on the patient's head here. And then you see the drill in the patient's head really goes then directly down to the cochlea, exactly in the trajectory that has been pre-calculated. You also can insert the electrode not by hand, but with the help of a robot. You see here one recent development, the so-called Robotol, which is a roboter that helps you to insert the electrode with very low speed, something which might be also important. And you see here an insertion tool we created. It's a pneumatic system. You can insert the electrode very slowly, precisely in the drill path as I have shown you. So this all will probably come into routine practice once the systems have been really integrated and become more handy and easy to use. Well, our vision is, of course, we want to give the best possible treatment for each patient, and we want to make it very individual so that we also can tell the patient what is the best treatment option for him, and then also do it in the most precise way as we can do. And with this, to serve our patients using all the possibilities we have available today, even it sounds sometimes a bit, let's say, very advanced or not yet in practice, but we know from history that many things that initially were kind of exploratory or experimental later became then routine. And I'm sure that many of these developments will go the same path into our practice. Thank you much for your attention.
Oh, thank you, Professor. I would like now Professor Laércio to make some comments or some questions about the wonderful presentation.
Yes, thank you, José. Thank you very much, Thomas, for your always very interesting presentations and full of new informations, and the huge experience that you have and always give us some new thoughts. I also just to comment a few things and to ask you some some doubts that I have. First, I like it very much your comment about the osseous, the bone anchored hearing aids, or not. We have not to say Baja today because it's a trademark, but the bone anchored prosthesis. The threshold of bone conduction is very, very, very important. And I like very much that you put that in the active ear, your limit for implantations is 40 dB. I think that this is a very important issue. And although the manufacturers say that we can put implants for hearing losses higher than 50–55%, I think that we should be care about this, and I agree totally that the limit of 40 dB would be more safe for the patients. And regarding the unilateral hearing loss, for the contralateral, we have to have a normal osseous threshold, 20 dB. It will be the better situation for a good diagnosis. So thank you very much to confirm these thoughts. After that, I would like to ask you about your experience with the vibrant sound bridge in the round window. That you have many cases when you put the vibration devices in the round window, and how are your results about this?
Yeah, I think the results are in principle are good, but we see a lot of variability in the results, and I think one reason is that the precision of coupling is still an issue. So we know about these differences in anatomy. So for instance, the width of the round window is very different. Also, the angle at which you can place your coupler is very different. And then, of course, we also have issue of how much space do we have to the hypotympanum. If you have patients with high jugular bulb, it can be difficult to create enough space to bring it in. So there are many issues which explain part of the variability. And then, of course, we also cannot control very well the preload. That means how much force is really on the coupler itself at the membrane. So this is something which makes it different to other coupling sites like the stapes head and even the foot plate might be something different. So I think this explains part of the issue. So we try to improve the situation by creating a different coupler, which allows us to control some of these parameters. But we also have this fibrosis that is occurring after surgery, which of course is very difficult to control. And I think the fibrosis might also detach the coupling site from the round window membrane. So you see to get some just forces that tear it away. So all this, I think, contributes to it. And but we know some ears we don't have another possibility to couple in the ear, and especially in chronic ears, we would not like to open, let's say, the foot plate to bring in a stapes piston or something like that, which from a mechanical point might be better, but from the biological risk, it might be not the best solution.
Great. Thank you very much.
Professor Lenarz, may continue.
Question. You said that you have a CT scan in every patient in post-op just to see the position of the electrode. Do you think even if we have a nice teleneurometry, you have to have the CT? Because we don't do that on regular basis.
Yeah.
Your suggestions?
Yeah, well, the point is just to also measure how deep we are in the cochlea. This has some issues for the programming, so that we take this information not only for checking the appropriate position, but also
to help the
see
program.
how deep we are and where the contacts are. No, that's I think it's still a matter of some research, but we see some correlation between performance and this depth of insertion.
Great. You also said that the earlier implantation in children, the better the results. What is your age limit for implantation? Do you think the 6 months is okay, or you prefer?
Yeah, I think you could, of course, we can identify the children very early due to universal neonatal hearing screening. But the point is, of course, that you have a very small child, and the risk of elective surgery is probably higher if the child is below 6 months of age. So we normally would then say we wait until their body is mature enough so that the risk of any surgery is, so to say, much less. I think that is one reason. And also, I think the parents often they need some time to figure out what to do, but that is very individually different. If you have post-meningitic deafness, for instance, then we also go for earlier age, at 4 months. I think the youngest we have implanted is something like 3 months. That was just after meningitis, and to let's say implant before obliteration occurs, which is then a difficult situation.
Okay. And the last question, Jose. You also mentioned that for hearing preservation, you can use a long electrode, but doing a partial insertion, and later, if the hearing decrease, you can reintroduce it or put in the electrode in the or covering a more space in the cochlea. But don't you think the fibrosis or any change in the inner ear can prevent this insertion or the?
Yeah, we have.
What your experience? Yeah.
Okay. Yeah, we have some experience in cases they who lost their hearing, and actually the fibrosis is mainly outside the cochlea. So you have it, as we know, in the mastoid and also in the probably close to the cochleostomy. But inside the cochlea, the fibrosis is very little. It's only in cases where we have labyrinthitis that you get more fibrosis. But normally it's only very thin connective tissue sheath that is around the electrode. And you can easily insert the electrode deeper without resistance, and then fix the electrode appropriately so that it stays in the cochlea. And we found this feasible in all the cases we have done. I think 3 or so we have now where this was necessary.
Thank you very much, Thomas. Thank you.
Okay.
Jose.
Thank you, Oswaldo, for your
Thank
questions.
you.
Thank you. It's early morning for you, no?
Yeah.
Yeah. Not that much.
Now it's okay. 7:30.
Yeah. Professor, I would like to ask you about 2 or 3 questions. First, about the conventional hearing aids in children. How early do you indicate the conventional hearing aids? Because recently there has been a proposal by a new joint that you should be even earlier for the diagnosis and hearing stimulation by conventional hearing aids in children, in small children. So how early do you go for this fitting?
Just in addition, just in addition to what I said to the question from Professor Oswaldo, we recommend, and we also do the hearing aid fitting in these very small children before implantation, so that we at least try to also use some residual hearing or even vibratory information in the children, so that they get attention to sound that surrounds them. So as early as possible, even if it's difficult with a small ear and everything, but we have expert pediatric hearing aid acousticians who can do it very well.
Sure. So even early as 2 or 3 months, you would go for the hearing aid fitting.
Yes. Yeah, we try as early as possible.
Yeah. Professor, about chronic otitis media, what would be your strategy for the surgery in this case? Would you do 2 surgeries, or would you do 1 surgery? What is your strategy for this patients?
It depends on what you want to place. I mean, a bone conduction device you can place without any other measures. For the vibrant sound bridge and also for the cochlear implant, you probably need a safe ear. And the point is that, of course, you should not have any infection, any risk of exposure of electrode or the actuator through skin breakdown. And that is the reason why we do first the ear surgery in order to get rid of the infection and the inflammation. Depends on what we find. Let's say we have just eardrum perforation, we'll close it. If we have some cholesteatoma, remove it first and then wait. And the second stage, then do the implantation. Now, in cases of radical cavity or canal wall down, or where we have cases where we cannot really do a closed technique, then we would go and do a subtotal petrosectomy with blind sac closure, so that we obliterate it with abdominal fat, and then we go in after 6 months and do the implantation. That is, I think, in our experience, the safest way. And we avoid this kind of complicated cases where you do only a 1-stage procedure. You do the eradication of the inflammation and at the same time the implant. In our experience, this has not really worked out very well. So we had too many cases where we had then an infection breakdown of the skin and so on. And so we basically have given that up.
Great. One last question, Professor, about Meniere's disease. In some patients, you may get improvement in the tinnitus and even in the hearing, but sometimes the patient still has dizziness or schwindel. And what would you consider? Of course, this is a rare situation. And how would you manage? Of course, we try medical therapy, but would you consider endolymphatic sac decompression or even intratympanic treatment in a patient that is already implanted?
Yeah. So, I mean, what you could do is to give him either the gentamicin, that could be one option. But what we do at the time of the cochlear implantation, for instance, we make a sac decompression. Because it's just in your way. So with the implantation, you can also do the sac exposure. So then you have this kind of treatment. If it's still persistent, then it can have different reasons. So one is the Meniere's, the other could be due to the implantation. It's hard to see. And to do some nerve section, I think we have done only, I don't know, 3-4 cases after implantation. Very rare that there was a need for that. But of course, you still also could do that you go in again and make your nerve section, retrosigmoid or even translap approach.
Oh, that's great.
Valeu seu som.
Okay. Do you have any other question, Professor Laércio?
No, that's okay. I am satisfied. Thank you very much.
We'd like to thank you again, all of you, and in name of Professor Nilvan Andrade, who is the chief in our department, we'd like to thank again and say it was a wonderful morning, and thank you, everybody.
Thank you for the invitation, and hope to see you in person very soon again. So, and hope we all do well, stay healthy.
Yeah.
and we can basically behave as normal.
Yeah. Is there a second wave? Is
Hmm.
there a second wave in Europe? Do you believe that it will be too bad as the first, the COVID wave?
Actually, we have a second wave now in Europe and also in Germany, and the numbers are much higher than in the first wave.
Oh, that's terrible.
But the severity, or let's say the number of severe cases, probably is not that high. It's different in other countries like Italy and so on. And I think it's there are many let's say answers why that is the case. Well, first of all, I think the social behavior is very different across Europe. No? So the northern countries they have more social distancing in any way. So we have many more people who live alone, or you don't embrace the others, you don't kiss them and whatever. So that's very unusual in Germany. So and the second is that of course our healthcare system is much more resilient than in other countries, because we still have a lot of hospital beds, a lot of hospitals, and also a lot of let's say emergency beds. So just for Germany, we have active 45,000 emergency beds now, which is 5 times higher compared to the population, on the population base, than, for instance, in the UK, or 3 times higher than in France also. So actually, we don't run that fast into some limits and then to make a triage and whatever. So this, I think, also helps to bring it down. The main point is, of course, that you need enough staff, enough personnel that can treat the patients. And that means that, of course, routine cases or other cases cannot be treated. So, for instance, cancer patients, we can't do the necessary treatment because all the resources go, or not all, but more resources go to treat COVID-19 patients. And I think that is an issue we have in the discussion. So how can you really keep the balance? That's basically. I don't know how in Brazil. I think you also had a very high number of infections, and also the mortality rate was quite high. What we heard.
Yeah, that's terrible. Maybe we'll get a second wave also. Yeah.
Here in São Paulo, the second wave is starting, but exactly as Thomas said, the mortality rate is very lower now. And I think they learn how to treat more severe cases. So, but the private hospitals especially are full of patients, because with the social liberations, parties and restaurants and younger meetings are increasing the number. But hopefully the aggressivity would be less than the first wave. But Thomas, stay safe and have a very wonderful weekend. Take some rest and stay safe.
Thank you.
Enjoy the beach. Yeah.
It was a pleasure. Yes. Now, yeah, great. Thank you.
Bye.
Goodbye.
Okay, take care. Thank you. See you. Bye.
Thank you. Bye.
Bye.